chairs, ladies and gentlemen, dear colleagues, good afternoon. Thanks for inviting me to give you in the next 15 minutes an overview of all the exciting data that you've seen before, but now in context to other data. I will speak to you about the 8-year freedom extension data, the 7-year non-word data, and the TTR data. You have heard this in the context before. I will give you more details so you can put this in context. It's important to understand for people who are not familiar with the freedom trial that you see that for the first 3 years for the registration trial we had a placebo arm and a denosumab arm, and then we had the option for the patients who had placebo before to go on denosumab. So we had at the end, after 8 years, we had people who had 5 years denosumab, and we had people who had 8 years of denosumab. And this, of course, gives us opportunities to look into the effect of denosumab in this population. This is the first result. If you see the left panel, and it was already shown, you see the BMD increase in the words of up to 18.4% in the long-term treatment, 8 years, and in the crossover group of 13.7% over the time of 5 years. And on the right side, you see the incidence, the fracture incidence in vertebral fractures. And you see on the left panel the placebo in white, and blue is the denosumab. You see the incidence going from in the placebo arm from 2.2 to 3.1 after 3 years, and in the denosumab arm from 0.9% to 1.1%. And then on the right side you see the extension. 8 years of denosumab, continuous treatment of denosumab, and we see here in year 8, 1.2%. If we look in the crossover group, again, these patients who had 3 years of placebo and then received denosumab, you see here the same effect. You have a reduction over the 5 years in the fracture incidence from vertebral fractures. Same standard of presentation. You see on the left side the BMD, and here you see it in non-word and hip. You have 8.3% over baseline in the denosumab arm from the beginning, freedom, 8 years of denosumab, and 4.9% in the crossover group. So 5 years of denosumab, 3 years of placebo. And it's interesting, you see in the placebo arm, actually the patients are losing BMD over the period. You would expect this in osteoporosis. If we go to the right panel again, in the middle you see the same, the freedom, the incidence rate for hip and non-word. You see it goes from 3.1 in the placebo to 2.5, and in the treatment group, in the freedom trial, from 2.6% to 2.2%. If we look now into the extension, the 8-year freedom, you see now in the 8-year an astonishing number of 0.7%. Yes, of course, we don't have placebo in here, but we have the incidence after 8 years of denosumab, continuous denosumab treatment. If we do this same thing for the crossover group, 3 years placebo, 5 years treatment, you see that we, after 8 years, we have an incidence of 1.4%. This was already shown in the first talk, and just to highlight here, we have on the main body, you see the placebo arm, then you have the crossover, and then you have the long-term. Crossover 5 years, long-term 8 years. And you see all the AEs, adverse events, 156, 99, 100 as the rate, subject years, and you see that's not really an imbalance in adverse events. However, you know that we had in the study 8 ONJs so far in this 7,800 patients, and 2 atypical femur fractures, which have occurred, one in the crossover and one in the long term. The summary, I didn't show you the turnover, but the turnover was shown before in the previous talks. The turnover is with denosumab is very potent. You don't see CTX coming up immediately. So after 2 or 3 days, it's down by 80%. We have a continuous increase in bone mineral density, and we have low incidence of fracture in vert, non-vert, and hip. This was the run through the 8-year data denosumab, which was presented as an old presentation as a late breaker at the ASBMR in Baltimore a couple of weeks ago by Sokrates Papapoulos. And now I'm turning to another very interesting part of this presentation at the ASBMR. Is this about the non-vert after 7 years in the same freedom extension trial? The background I've jumped because it was already explained to you. Interesting here, just in the middle, you see we have a vertebral fracture reduction by 68%, non-vertebral fracture reduction by 20%, and in hip fracture reduction by 40% in the freedom trial. And the idea was, of course, from Serge Ferrari and his group to look what is going on. Now we have the crossover, we have the long term. Is there something we can see after 3 years, 4 years, 8 years of increased evidence? So what they've done, they wanted to see if there is beyond the 4 years any additional BMD increase, and of course then hopefully in incidence, lower incidence in fractures. And what they've done here, it looks very complicated, but at the end, they calculated the ratio between year 1 and 3 and year 4, and then this they did with the long term and the crossover, and for the other part, just for the long term. And what happened when you look into this if you look at the same data we have presented year over year, and you look with this angle, this approach to this data, you find that is from year 3 to 4 in the crossover, you have a drop from 2.0 to 1.4 in the non-vert, and in the crossover from 2.2 to 1.4%. So something is happening between 3 and 4, which is additional evidence that we can continue increased BMD and have a result of lower fracture incidence. If you look at this together as in a scale, you have the first 3 years of 1.98, and then to the 4th year 1.43, and the 4th to 7th year 1.45. It means something is happening after 3 years of treatment, and you can still continue to increase the BMD and have an effect on your bones. So this is happening despite that this patient getting older, the risk of having a fracture increase, and still continuously this denosumab is providing this kind of help. So Serge Ferrari and his colleagues concluded that this long-term therapy with DMAP may provide further non-vertebral fracture risk reduction over time, and despite that this patient getting older. And this contributing factors that might explain this observation is sustained reduction in bone resorption, yes. Continuous gains in BMD, as shown. A decrease in cortical porosity with associated increased cortical mass, as seen as well. You've seen the exciting data from Sebasi. And increase in cortical and trabecular strength observed with DMAP. Personally, my view is a lot of things that really are the mode of action of denosumab because it's so unique and it goes to both compartments differently like any other product on the market. Last but not least is I'll give you an overview about a TTI, TTR, a different angle to approach this, the higher risk patient population. And what we've done, what Jack Brown and his colleagues done, they looked into special groups from both transition data studies. TTI was transition to abandonate, TTR to resabronate. All patients have been pre-treated with bisphosphonates. The TTI study was mainly conducted in the US and some Southern European countries, and the TTR was mainly conducted in Canada and Europe. This is the design as shown before, and it's important to see that these people, these patients, these women, had to be older than 55 years old, and they have been previously treated with bisphosphonates. And they had either stopped or they had a very low adherence measured by osmosis. And here is a point which is new to you. It was new as well for the colleagues in ASPMR, because here is a way the investigators try to define higher risk of fractures in this patient group. And you see on the left side all the reasons, all the arguments you have to have fulfilled to be in higher risk. At the end, you see the percentage of patients who have been on higher risk. And when you tick off, people had still despite the treatment they had before, they still remained on higher risk. Baseline demographics, of course, you can see a little bit difference between the higher risk and remaining on risk, but it's not dramatic. And here you see the results. You see that you have in this group who are on higher risk, you still have this additional BMD increase, which hopefully then translates in the efficacy of risk reduction for fractures. And here the bone turnover in the groups. You see the typical pattern of denosumab of being very potent in the CTX, going down compared to the oral bisphosphonate, resabronate, and the abandonate. And here always important the AEs, and there have been some kind of numerical imbalance in one of the studies for the TTI study. Again, we have to mention that this is an open label study where sometimes we get numerical imbalance, but in general there's no clustering or no new safety signals. And as a summary, you can see that if you transfer patients from bisphosphonates and compare it to other bisphosphonates and denosumab, you still see an additional BMD gain in these groups, which translates at the end in a hopefully lower incidence of the fracture rate. Conclusion, transitioning from DMAP was safe and more effective in increasing BMD. In both trials, we reached superiority over the bisphosphonates. They have been treated previously with BPs, and this is an important role. If you treat it with BPs, but you're not adhering to your treatment, the best treatment is not working. So here we can see it. People sometimes not taking the tablets, and they means there's lack of efficacy just because of lack of adherence. And this finding support this DMAP is an alternative option for this kind of patient who still remains on high risk and they need the treatment to avoid fractures. Thank you.